This is Blood and Cancer, the official podcast of MDedge Hematology Oncology. And welcome to episode 122 of Blood and Cancer. I'm Nick Andrews, and I'm joined by the host of the show and the editor-in-chief of MDedge Hematology Oncology, Dr. David Henry. And Dr. Henry, I hope you made it out on the other side of Thanksgiving alive, and there's not a calorie imbalance, and we're all good to go for our month of December.
Well, that's true. There's no calories left around, even with a much smaller attendance. The calories seem to disappear and seem to be in me, as well as a few others. So we're getting ready to see if we can do it again for the other holiday season coming up, Christmas or whatever holiday you might celebrate. So it was different, interesting. I'm sure many people had this happen, and it wasn't that bad.
Yeah, I always consider calories and credit to be along the same lines in that I will deal with it in January.
I like that. How's that working out for you?
About like it sounds. Like probably not that smart, but also not that bad. I mean, it's okay. Like I deal with it in January and February and June.
Well, I found going to the gym doesn't help credit, but maybe we'll find some way. Maybe if you work
baby steps. It's mental credit at that point, Dr. Henry. It's mental health. It's mental credit. Anyway, let's talk about our episode this week. It's an interesting topic for me personally, just because to volunteer some personal information. I am a transplant recipient. I have corneas, and so this is something that I did a lot of Googling on for my small organ transplant versus rejection, and pretty scary for someone who doesn't know what's going on. However, in this instance, it seems like there's some movement here, and this is, of course, graft-versus-host disease.
Yes, and I remember when you had that done, and I'm happy to see that it worked out so well for you. And this interview today on this episode is about graft-versus-host disease and how to game the system, so to speak. So we started off with Dr. Ferrara talking about what is it? I always like to start basics and work up. So what is it? And we went through what he sees, how bad it can be. It's a real problem, the symptoms and physical findings and lab findings. So then we got into what his research is all about, which is not so much preventing it, but detecting it's coming. And he and his team have developed two markers they call REG3-alpha, REG3-alpha and ST2. And they have this wonderful algorithm, they call it MAP, but it's the magic algorithm probability. When they're measuring these biomarkers, they can tell it's coming on strong. You better get ready and tap it down. Yeah,
when I was listening to this, it reminded me of it. And a lot of things remind me of this in terms of making sure everything's on the same page. When you're carrying groceries in from the car and you've got, say, like the bag of oranges and an orange drops. So if you try to grab for the orange, then you're going to drop the milk or the eggs. And having the information that the orange is about to drop before it drops is going to be so helpful to know that you can make it into the house without dropping any of your groceries.
Yeah, good analogy. So that this early warning system, their MAP program, very clearly and nicely goes through all that. So I think this is a very enjoyable episode for something that we face a lot at the highest level when people are getting allografts of whatever type.
Yeah, absolutely. And remember, there are show notes available wherever notes are found in your app, of course. You can contact the show at podcasts@mdedge.com. You can follow Dr. Henry on Twitter, tweeting out some of the best articles from MDedge, where he's the editor-in-chief of the Hematology and Oncology section. And, of course, some research as well going on Dr. Henry's Twitter page. That's at David Henry MD, and MDedge Hematology Oncology is available on Twitter as well. Well, it's a weird time. I don't know if you read the news, but apparently there is a secret intergalactic space society that's waiting for humanity to be ready for them. This is breaking news. This is not me making this up. This was reported by news sources. Someone really said that, and they were really serious. So I'm you know what? 2020 is not over. Let's turn up the alien invasion part of the year.
Now, how will we know when they're here?
That's a good question. And how does he know that they're here? And more interestingly, do I have to have my credit and calories in line to get to go to the Intergalactic Federation?
To all our listeners, because as the next few episodes go along, we will find out when they're coming and if they're here.
Absolutely. David, you and I will be the ones on top of that. All right, for Dr. Henry, I'm Nick Andrews. Let's stick around for this interview.
Bye-bye.
Go beyond the headlines and hear the full story on Cleveland Clinic's Cancer Advances podcast. It's the medical professionals' trusted source for exploring the latest innovative research and clinical breakthroughs happening in the field of oncology. From the highest profile cancer trials conducted at our research facilities to understanding how they impact your patients, Cleveland Clinic's world-renowned experts take a deeper look. Listen to the latest Cancer Advances episode by visiting clevelandclinic.org/Cancer Advances podcast.
I'm your host, Dr. David Henry. You're listening to Blood and Cancer. And so I'm delighted today to be talking to Dr. James Ferrara, who is Ward Coleman Chair in Cancer Medicine at the Tisch Cancer Institute, Icahn School of Medicine at Mount Sinai in New York. And Dr. Ferrara, thanks so much for joining us today to talk about GVHD.
It's my pleasure.
Why don't we start with what's GVHD? I guess in the auto setting, not so much, but in the allo setting, yes. So what is this phenomenon and how do you recognize it?
Right. So for an allo transplant to work and eliminate all of the malignancy, we rely on an important graft-versus-leukemia effect, which is mediated by the donor T cells in the graft. Now, those donor T cells respond to minor histocompatibility antigens that are on the malignant cells. But those minor histocompatibility antigens are also on normal tissues. So graft-versus-leukemia is very tightly associated with graft-versus-host disease. And although we want the one and don't want the other, it has been very difficult to separate them. So we protect all of our allotransplant patients with prophylaxis against graft-versus-host disease so that it doesn't become too severe. That prophylaxis usually consists of two drugs, something like a calcineurin inhibitor like cyclosporin or a tacrolimus, and then another drug, sometimes that's methotrexate, sometimes that's sirolimus. There are a variety of combinations.
And this is to tap down the body's immune response to the graft.
It's actually to tap down the graft's response to the body.
I beg your pardon, right.
So it's like the flip side of rejection.
Okay.
Because the patient has received high-dose radiochemotherapy that has eliminated its own immune system and or his or her own immune system and essentially left them totally defenseless in front of this new immune system that will eliminate both the malignant cells, but can also attack normal tissues. So despite the fact that we've tried to protect everybody, almost slightly under half of all of our patients will still develop some form of GVHD.
So just before you go there, if I could interject, so whom are you treating? Are we doing leukemia, lymphoma, or anybody else? And if I recall from the recesses of my mind, you prefer not to use an identical twin as the donor. And could you mention why that's not a good idea?
Absolutely. Thanks for asking both of those questions. So we don't use identical twins because identical twins who have exactly the same genetic component, the immune system of one will not react to minor histocompatibility antigens in the other twin because there are no histocompatibility differences. So you have neither a graft-versus-leukemia effect or a graft-versus-host risk. So we like to use HLA identical siblings, but that's fewer than 1 in 4 patients actually has a suitable HLA identical sibling. And so now most of the time we use unrelated donors, but those donors who may be matched at HLA still will differ at multiple minor histocompatibility loci, which essentially increase the risk of GVHD, as well as perhaps giving us a slightly stronger graft-versus-leukemia effect. Mm-hmm. So we don't, and with an auto transplant where you're putting your own immune system back into yourself, there's also no genetic difference to drive the T cells. So it's really only when you have a donor that is genetically different from the recipient that you can get GVHD.
Okay, so as we're about to go into it and how to recognize symptoms and lab and physical findings of it, just again, we're only going to be talking, or your focus is on the leukemic Anybody else? The lymphoma, the myeloma?
So it's mostly leukemia and lymphoma, and those are high risk leukemia and lymphomas. Multiple myeloma is usually not treated with an allo transplant. All of those stem cell rescues are usually auto transplants. So most myeloma patients will not get graft versus host disease. Just to say, there are some hematologic hemoglobinopathies like sickle cell disease that can also be cured by allo transplant.
Mm-hmm.
But that's still a relatively small population. And there are other tiny populations that are treated in pediatrics. For example, congenital immunodeficiency syndromes can also be cured by hematopoietic cell transplant. But there you don't want any graft versus leukemia effect. And GVHD is just a risk, pure and simple.
So we're going to do this, and of course we're going to get into your research and how we can see who may or may not have worse or better and biomarkers. But so what's so bad? Someone has GVHD, your resident says to you on attending rounds, he's got it, and you say, well, what are the symptoms, physical findings, and labs that tell you GVHD is occurring?
Right. So in general, there are two forms of GVHD, acute GVHD and chronic. Chronic GVHD usually occurs months to years after the transplant. It's a complicated disease about which we may talk a little, but most of today we're going to talk about acute GVHD. And the majority of, in about half of the cases, that happens in the first month. It's usually in the first month to two, although it can spread out even to months 4 and 5, but that's a minority of cases. In former times or earlier times, when we were using very intensive doses of chemoradiotherapy to condition the patient, GVHD often occurred while a patient was still in the hospital recovering their counts. That is actually not the case now. Most patients are discharged from the hospital within 3 weeks. It's usually a week of conditioning and then engraftment. So we call day 0, the day of the infusion. A patient is by that point neutropenic. It usually takes about 12 days for the counts to recover. And then in the following week after the counts have recovered, patients start eating again, they're drinking, and we try to get them out of the hospital very quickly. But what that means is that unless GVHD symptoms occur early, and we'll talk about what they are in a minute, most patients now actually develop even acute graft-versus-host disease outside of the hospital.
Okay.
And that has actually complicated some of our care because the severity of the disease in its very early stages does not normally predict outcomes.
Mm-hmm.
And so people are unsure of what to do. So let's talk a little bit about what the symptoms are of acute graft-versus-host disease.
Yes.
There are 3 primary targets: the skin, the liver, and the GI tract. The skin is the most common organ that's affected. I tell my students that measles is a rash that's like GVHD, because in fact, most medical students now are more likely to see graft-versus-host disease on a transplant ward than they are to see measles.
Mm-hmm.
Now, there's been a little bit of a change with that as the vaccinations have been spottier, but it is these 2 rashes are very similar. They're vesiculopapular. The extent of the rash determines the stage of GVHD in the skin. In the liver, we use increase in total bilirubin to measure the stages of liver disease. And in the GI tract, there can be persistent nausea and vomiting. That can be one sign. But more importantly, there is lower GI tract disease, which can be a copious secretory diarrhea, which can go up to liters a day. So the skin, the liver, and the GI tract. All
Okay.
three of those organs are evaluated, and we get an overall grade between 1 and 4, 4 being the most severe, 1 being a skin rash that is usually less than 50% of the body surface area.
And these can be morbid/mortal.
Unfortunately, when GVHD is severe, it is definitely lethal. And in fact, it probably kills GVHD, or the complications of the treatment from GVHD probably kill about 20% of our transplant patients total. So it is the major complication of allogeneic transplant, and it is something that is still requiring active additional novel strategies, both to prevent it and treat it. Now, I mentioned before that graft-versus-leukemia and graft-versus-host disease are very tightly linked. If we could engineer the graft or our treatment so that all patients got just a little bit of GVHD to guarantee a graft-versus-leukemia effect, we would probably do that. But the problem is, because the disease is mediated by T cells that have clonally expanded and over which we have very little control, we don't know when symptoms start whether the disease is going to be mild, moderate, or severe. When it's mild and it is limited to the skin, we can use topical steroid creams. And in fact, that's not a big problem. But the big issue is that at the onset of symptoms, the severity at the onset does not predict the course of the disease later on. And that's been something that we really have wanted to know, because if we know that a patient is who presents with a mild skin rash, that's going to stay a mild skin rash, then we use just topical creams. If we know that it's going to progress into the GI tract and the liver, then we would give them much more heavier systemic immunosuppression. So for lots of our patients who get treated for acute GVHD, when we don't know how severe it's going to be, most of them get systemic steroids at 1 milligram per kilo as a starting dose. Lots of those patients are overtreated, and a fair number of them are undertreated because we don't actually know which patients are going to progress and which patients are going to respond to treatment.
So it might be better to have some biomarker clues as to who the bad and the non-bad are.
Some tests.
Mm-hmm.
And just to say that for 50 years, we've not had, until last year, we've not had any drug approved for the treatment of graft-versus-host disease, except for systemic steroids. So that shows you how slow the advances have been. Despite all we've learned about cancer and all we've learned about immunology, we're still using kind of Stone Age clubs of systemic steroids to treat this disease.
Well, that segues us into your research into hedging your bet. And I understand you've studied the biomarkers ST2 and REG3-alpha.
And REG3-alpha.
So we can't wait to hear it.
Yeah, so let me tell you first that skin disease alone will often respond to treatment. It's the GI tract that gets our patients into trouble. And that is, for lots of different reasons, the GI tract is the most difficult organ to treat and is, in fact, the least responsive to treatment. So when we started to look for a laboratory test that could predict outcomes, we focused, in fact, on the GI tract, although initially we were agnostic about what a protein biomarker, a serum protein biomarker might show us. But in fact, what we found was that there were 2 proteins that are produced largely in the GI tract that are damaged very early. When the GI tract is damaged early, these proteins flood into the systemic circulation, and they can actually tell us who's got a damaged GI tract very early, even before one has symptoms like diarrhea. So we actually now describe these two biomarkers, regenerative-3-alpha and ST2, which is the soluble IL-33 receptor. We can measure these proteins in the blood, and they act as a kind of liquid biopsy of the GI tract. And in particular, they are very reflective of damages in the crypts. And the crypts are critical to regenerating all of the lining of the intestinal mucosa. So it turns out that these biomarkers, which are more sensitive and more specific than the volume of diarrhea or even nausea and vomiting, they can tell us whether, both at onset of disease, whether someone has crypt damage and needs more intensive treatment, or whether they don't have crypt damage and you can use less intensive treatment.
So if damage is occurring, I'm guessing these two markers would rise and be findable in the blood.
That's right. And what we've now been able to show, because we monitor in our consortium we've got about 24 transplant centers where we monitor about 700 allogeneic transplants a year. And that's about 300 to 350 cases of acute graft-versus-host disease. And we have very carefully curated clinical data, and they send us serum samples every week. So now we've got 4,000 patients that we've been able to look at in various combinations. And we can tell that if your biomarkers are high in the beginning and they go low, you've done well. So you can use this. So our consortium is called MAGIC, the Mount Sinai Acute GVHD International Consortium. And we call these biomarkers the MAP, the Magic Algorithm Probability, because you put these two biomarkers into an equation, you get a single number, and that number tells you whether you're high risk, low risk, or intermediate risk. And you can follow these numbers now just the way you follow other laboratory markers of disease and tell whether the GVHD in the GI tract in particular is getting worse or it's getting better. So and what we've been able to find is that even when for example, GVHD does not seem to be responding to treatment after a week of steroid therapy, we can tell by looking at the biomarkers whether these patients are actually responding, and in particular, whether the GI tract is responding well and the crypts are healing or not. And we can divide them into two groups, to a low risk group and a high risk group, one group where you can start tapering your steroids, even if you don't yet have a complete response to, for example, skin disease. And we because we know the outcomes of these patients, we can guide immunosuppressive therapy based on the changes in these biomarkers over time.
So have your data borne this out? So you see by detectable levels of these markers, high or low, how hard to press for your interruption of disease treatments, so that when they go low, you can back off a bit, the patients do better, and when they go high, you have to really stay on top of it with medication.
And perhaps even increase the medication.
Understood. Okay.
Yes, and these biomarkers predict both the response to treatment as well as eventual survival or mortality.
Has this been taken up by other centers?
Yes, it has. The biomarkers are available through ViraCore. One can send these out. It's you have to send the blood sample to them, but they can turn around the test within a day. Before the problems with COVID, what we know is that there were over 50 centers in the U.S. That had sent at least 1,000 samples to ViraCore for testing in 2019. So this is now becoming increasingly part of people's standard practice. Here at Mount Sinai, we are doing clinical trials based on the biomarkers. But if a patient isn't eligible for a clinical trial, or for some reason, we actually send the biomarkers out to ViraCore ourselves, so that we get a an FDA-approved laboratory to run these biomarkers. So it is starting to impact clinical practice across the country.
Well, that was my next question. So you've really made discoveries which are clinically useful with these two markers, but your clinical trials, what are you studying now to take it a step further?
So we're taking two different approaches. The first approach is for patients who have high-risk disease at onset, and that's about slightly less than half. It's maybe about 40%. So those patients, we know that the first time we see them, that their GI tract is in trouble and that there's damage, and so we give them steroids plus another more intensive medicine. In one of the trials, it's a monoclonal antibody. In another trial, it's an additional immunosuppressant. Then for our other patients who actually don't have GI disease, we are trying to reduce the number of steroids and do more rapid tapers, because many clinicians will tell you how difficult it is to taper steroids. The steroid tapers are slow. Our patients are at increased risk for viral infections because they're on weeks and weeks and sometimes months of systemic steroids. And so now we are taking those patients who are at low risk and actually putting them on a rapid steroid taper with the hope of getting patients completely off of steroids within 4 to 6 weeks. And also following the biomarkers to make sure that, in fact, there has not been a reversal, that now that as we rapidly taper this, that patients are, that the GI tracts are still in good shape.
Well, that's really eloquently simple. So those who need more biomarkers get more. Those who can de-intensify get less, and of course get off these medications sooner, faster. Really very straightforward.
Well, that's the
idea.
Goal. We now are starting to have new drugs and better drugs. Ruxolitinib has been approved for steroid-resistant GVHD, and our prediction is that we may be able to, if these drugs turn out to be effective, we may be able to save steroids, because steroids are so bad for a reconstituting immune system.
Yeah.
We may be able to save steroids until later and use non-steroid medications to do the low-risk disease and only use the steroids for the high-risk disease, and actually kind of flip the paradigm so that it's only patients who are resistant to the first non-steroid meds that actually get the steroids later. It's a check 1, 2, and
Got it. We're recording in early November. Will you be presenting any of these data at the ASH meetings coming up in about a month?
No, we won't be. We presented them last year in terms of the monitoring biomarker. We're just getting the results from our clinical trial, so it's probably going to be ASH of 2021 where we actually present those results.
When we're all together in some really nice city.
That's a consummation devoutly to be wished.
Absolutely. Well, Dr. Ferrara, I can't thank you enough. I want to remind our listeners, we've been talking to Dr. James Ferrara, who is the Ward Coleman Chair in Cancer Medicine at the Tisch Cancer Institute, the Icahn School of Medicine in Mount Sinai in New York, as we've all heard from the sirens in the background in New York. And we're listening to Blood and Cancer podcast, which also posts on mdedge.com/hematology-oncology, our website. There'll be show notes, bullet points. We'll put some references also to your work and your research. Dr. Ferrara, thank you very much for taking the time to talk to us today.
Thank you so much. It's been my pleasure.
Likewise.